So shared cancer care is a model of care where the care of the patient is shared between the primary care practitioner, usually the GP, and the specialist centre, the hospital, and the various specialties within the hospital. It's a model that's been around for a long time, but has been a focus of Cancer Australia for the last 10 years. It can work extremely well. It isn't simple to set up. It's not as if you push a button and suddenly shared care works. But if it's designed properly, and if the patient's individual requirements of the patients are considered, it's a win-win-win. It is better for the patients, it's better for the GPs, and it is better for the hospital. But a key part of it is having a system where the individual needs of the patient are assessed, where the information is properly collected and available so that the care, that the GP knows what has happened and what's expected, and also the patient knows what's happened and what's expected. If that can be done, it really is a great advance. Recently, the statements from Cancer Australia highlight that shared care is the preferred approach to follow-up for those who have been successfully treated for breast cancer, on the basis that it is feasible and that it is better. It delivers just as good a care, more conveniently, less expensively, and quite importantly, from the hospital point of view, it frees hospital resources so that the next lot of patients are able to get better access and get more time. In the shared care model that we've established here, the nurse is critical. And the way we have done it is at the time of initiation of shared care, at the end of definitive treatment, the patient has a scheduled one-on-one consultation with the breast care nurse where a series of questions are addressed. These are designed to work out where the patient's up to, what her issues are there any unmet needs? If so, how can they be met? And then to work out with her what her follow-up program will be. And that's where working out how much follow-up should be done, should be directed by the GP, and how much from the hospital is determined. But that nurse-led clinic where the survivorship care plan is developed is critical. You know, that is why our program has been successful.
Most patients who get cancer will go to their GP or their local practice as the first stop, and that's what will launch them off on this journey. So I think primary care is really the ideal place to look after the patient in a holistic way after they've been through a cancer experience. And so for me, survivorship's all about how we put you back into your own community in the best way we possibly can. So what in primary care, the ability to access psychological support, nutrition advice, local services like physiotherapy, occupational therapy, even more specialised things like speech pathology, they're all out there in the community, and GPs and their practice nurses have links to all those people and know who will fit with what particular patient. That's why if we don't engage with community practices and community care in helping our patients along their survivorship journey, then we're failing our patients just as much as if we failed to treat the actual cancer, the biology of their problem.
APNA supports nurses' increasing roles in supporting survivorship care within primary health care. Nurses bring a lot of skills and capabilities to patient survivorship care. They're able to identify and provide that psychosocial support for patients who are coming out of the hospital system. They're able to enable them and make sure that they have the information and support that they need during that transition period from acute to primary health care. So nurses are ideally placed because they're able to have those change conversations with the patients through enabling sustained behaviour change, which will enable risk reductions for when patients are going back into community care and back to their normal life.
So I think by and large, nurses are far more attuned to all those other things that make up the patient's environment, how this cancer is affecting this patient and their employment or their caring responsibilities at home, how that affects the immediate family, so their partner, but their kids or even parents who they're needing to look after, and then their wider network. And so I think that's where nurses in general practice or in community practice can help patients to navigate the resources that are out there for them.
So the nurse-led consultation within the team approach to transitioning a patient to shared care is a one-off up to 1 hour consultation, either face-to-face or by telephone, with the nurse specialist and the patient. So it's actually targeted at a particular time at either 6 months or 12 months from their original diagnosis. At a time when their acute care has completed. They may still be having their ongoing endocrine therapy, but they will have finished their surgery, their radiotherapy, their chemotherapy and their targeted treatments. The patient will be invited to this nurse-led consultation and they will be sent 3 quality of life self-report questionnaires that they complete and they send back. That enables the consultation to go ahead. So certainly we look at endocrine management, their tolerance, their adherence to that. We can cover menopausal issues, sexuality, fertility, body image, fear of recurrence and uncertainty for the future. We will cover bone health, nutrition, exercise, alcohol, smoking cessation, relationships and work, and a full range of things that women may have experienced. We also look at life experience and resilience that they certainly may have found that they've had through the albeit challenging time. So we can discuss all of those issues with them. So I see the nurse's key role in the shared care model as educating patients and members of the healthcare team regarding shared care. What that means, how that looks, and the process of it. It helps to provide confidence for the patients and the health team to understand what that means, knowing that what that does is facilitates timely, consistent, coordinated and effective communication between the patient, the specialist and primary care. The patients and the GP know the things that are important to be fed back to the specialist team. That may also include returning the patient to specialist care if there are issues of concern. There could be issues with possibility of recurrence. That could be local or metastatic recurrence. It could be side effects and tolerance of their endocrine therapy. It could be concerns about imaging or any other questions of care. So the nurse-led consultation and care plan, which really helps both the oncologist and the general practice to actually have a good sense of those roles and responsibilities. The feedback from patients who've been through a nurse-led survivorship clinic is that they feel that they've had an individualised conversation about things that are important to them. They continue to have their follow-up care with their specialist as well as their GP, but they find that this actually enables them to discuss the things that really matter that sometimes they've not been able to address at those appointments.